angios called cutting balloon, rotablation, IVL, ELCA, or now we have orbital. So straight away I'll come to the case. This is a 89-year surgically refused patient, non-diabetic. And if you look at the angio, severely calcified from ostium, there was a very short left main, fortunately. And we did a rotablation, 1.25 followed by 1.5. And you can see there are nice polishing of the rota and the distal calcium, which is very well modified. So pre and post imaging is very important. You can see rota polish here. But if you come to the osteal location, there is a dirty looking, very less shiny calcium. This is a calcific nodule. And osteal lesions are notorious for that, and we realized that, but that time we didn't have an orbital, it was not available, so we dilated with 3 into 10 millimeter Wolverine balloon, prepared the lesion. You can see the rotablated calcium plates were fractured. That is important to demonstrate the fractures, and we deployed 3 into 38 giants and 3.5 into 8 giants overlapping from the ostium, and post dilated at 3.5. But unfortunately at the ostium there was a perforation. So we realized that is the nodule which is perforated, because if you see this nodular wall will not expand, the other wall is absolutely disease free. If you are going very aggressive on this, if you are not careful, you can perforate the vessel here. So that's what happened, but fortunately a graft master was put. If you can see there is a heavily calcified left main, and there is a large left territory despite of grafts. The grafts were not for serving any purpose, and right was diffusely diseased and calcified. So what I'll just skip these NGOs. And what we did an OCT, so I'll skip the run because of the shortage of time. You can see the calcium is so thick and is deep medial calcification, and there is a layer of intima over that. So this medial calcification with a large lumen, the rotablation is not going to do anything, it not touch the calcium. So this is an ideal case where you have a nodular calcium here, there is a thick plate of calcium, you must do IVL in this case. And so 4 into 12 millimeter IVL balloon was taken. You can see it was not expanding at 4 atmosphere, and after that with subsequent pulses it expanded fully. That's a good sign. And we did a post IVL. You can see the cracks here. So demonstrating cracks before opening a stent box is very, very important. And you can see multiple cracks in the calcified lesion in a large vessel with deep medial calcification. That's how imaging guides you how to select your hardwares, and a stent was put, and finally there was some malapposition which was opposed by a 4.5 millimeter balloon, and there is a beautiful final result with a satisfactory MSA. So then we took this is the right coronary, and if you realize the balloon, the OCT catheter is not crossing, it's just not allowing the OCT catheter. When there is an uncrossable lesion, straight away 1.25 millimeter burr, rotablation followed by a 1.5, then cutting balloon was done. And before doing a OCT, the patient started having some chest pain with the ST elevation, so immediately the patient was stented with 3.538 stent followed by a final OCT run. And one can see there is a large lumen 5.5 with a very good end result in a very severely calcified, and the final result is really good. Now the third scenario most oftenly we see is a neoatherosclerosis with calcium, that is known as neocalcinosis. Inside the stent you have calcium with neoatherosclerosis. This is a very simple looking post PTCA long follow-up, 8 years old PTCA. One can see there is tight stenosis. If you're not doing an imaging, you can go with a cutting balloon or something and dilate that lesion and put another layer of stent in a neoatherosclerosis. Without understanding the mechanism, it will be disaster and the patient may come back again. But if you look at the OCT here, you can see there is a stent layer here, and there is a large chunk of calcium inside the stent with neoatherosclerosis. So this is neocalcinosis, is a process of atherosclerosis inside the stent, and you can see that a large chunk of calcium along with the stent is outside. So imagine there is a calcium layer and there is a stent layer. If you are not preparing this lesion, you will run into problem of underexpansion again, and the patient is going to come back again for a third procedure where you have very little answer and there are 2 layers of stents with a sandwich calcium in between. So this is the ideal case for IVL. We took a 3 into 12 millimeter IVL balloon followed by a Wolverine cutting balloon, and one can see this lesion how beautifully is prepared now. It's all cut throughout, and this is the vessel which is prepared to take a stent very well now. And this is the fracture, and you can realize the stent expands so beautifully. Yeah, I'll just go to the last case. And the final OCT was very good. And this what the last is contemporary use of IVIS and OCT in ultra low contrast, 78-year female with the angioedema somewhere outside, and these were the mobile picture available. We didn't have the CD, so RCA was uncrossable lesion, so we took a rotablation first. The rota was done and a saline OCT was done. You can see the beautiful saline OCT with a large chunk of calcium. Then you can see the rota polishing of the calcium here with some fracture here, and you can see the same thing in the IVIS also. There is a rota polish here, and we did a IVL followed by rotablation of 3.5 into 12 millimeter with a guide plus support, and this was the IVL balloon dilatation 3.5, multiple pulses were given, and there was 3 ml contrast injected. The patient had a asystole transient for 3 to 5 seconds. So you can see there are calcium fracture all around after the rotablation cutting balloon and IVL. And the same thing is seen in the IVIS also. You can see the fracture. This is most important to demonstrate fracture before putting the stent. And there was some doubt in the OCT, saline OCT. So we did an IVIS to see, and there was, to our surprise, there was an ostial hematoma in the RCA proximal ostial. So this is the contemporary uses of OCT and IVIS which helps each other, and we can see there is a large hematoma in the ostium which was very adequate. So to conclude my talk, angiographic severe calcification leads to stent under expansion and associated with higher rate of TVF and long-term bad outcomes. In presence of severe angiographic calcification, an algorithmic image-guided approach can help to select your optimal hardware for optimal modification, and device selection depends on intravascular imaging, finding whether you take an IVL, cutting balloon, rota or whatever, and calcium fracture. Nodular debulking should be imaged before stent deployment. Thank you very much.
Because if you take a NC balloon and you see it dilates well, it indicates that your fractures have taken place well.
You see, if you are taking an IVL, it's a very expensive procedure. If you have opened a OCT catheter, no harm taking an OCT run to demonstrate whether you have fractured the calcium. It takes hardly 1.5 minutes more.
Because in the last case, you have been doing both the procedures.
Yeah.
And with that contrast.
That we decided because it was minimal contrast, so we kept IVIS ready. So just for academic thing, we just try to do both the procedures simultaneously.